Hi, thanks for joining us on the Cancer Has No Borders podcast. I'm your host, Zach Randles-Friedman. Today, I'm really excited to have two new guests on our show. Today, I'm joined by Caroline Berchet, who's a health economist at the OECD, which is the Organization for Economic Cooperation and Development, and Sebastian Bojkow, who is a Senior Director for Market Access at BeOne. So Caroline, welcome to our show. Sebastian, welcome to the show. Thanks so much for being on.
Thank you.
There's a few things you should know before we start this podcast about Central European region. So cancer mortality is significantly higher in Eastern Europe. Countries like Hungary and Croatia report over 300 cancer deaths per 1,000 inhabitants, while Switzerland and Liechtenstein maintain rates under 200. This is a stark contrast, highlighting unequal cancer care outcomes. Survival rates for cancer vary dramatically. The 5-year survival rate for common cancers is around 62% in Northern Europe compared to just 38% in Eastern Europe. This is driven by the differences in screening, diagnosis, and treatment access. Access to innovative oncology medicines is unequal. In Germany and Austria, over 80% of newly approved cancer treatments are available, while most Eastern European countries fall well under the EU average of 70%. Cancer medication spending reveals a financial divide. Western Europe countries invest 90 to 100 euros per capita in new oncology drugs, while Eastern European nations spend under 15 euros, constraining access to the latest treatments. Eastern Europe has limited access to oncology clinical trials. In 2023, Western Europe countries hosted more than twice as many oncology trials per capita compared to the East. Okay, so before we get started, can you briefly explain to us what you do at OECD, Caroline?
Yeah, sure. Thanks first for the invitation. I'm very pleased to join this discussion today. So in the OECD, we have 38 member countries, and our mission is to promote policies to improve the economic and social well-being of people. So to this end, we produce data, forecast, and policy reports, and also we provide recommendations for government on a wide range of topics. So economic growth, employment, education, taxation, or social policy, just to mention a few. So this helps countries aligning policy, but also to identify best practices and to provide a platform for discussion for countries. In the health division in particular, we measure health system performance across countries, and we provide policy analysis and advice, so on a wide range of topics again. But we have a specific project on cancer jointly with the European Commission. And the aim is to develop the European Cancer Inequalities Registry. So this registry aims to identify trends in cancer burden and cancer care in the EU, and also to highlight inequalities, both between countries, but also within countries by population groups, so gender, socioeconomic status, and migration status when this is possible. So as part of the project, the OECD and the European Commission have released last February some country cancer profiles for the second edition. So we have 29 country reports, so one for each member state, plus Iceland and Norway. And it provides a wealth of data, policy discussion, and qualitative analysis across the cancer spectrum in EU member states and Iceland and Norway, as I just mentioned.
Thank you so much. So from your research, what are the most pressing disparities in cancer care across CEE?
So in this report, we can see that inequalities in patient access to cancer medicines and ensuring access to new cancer medicines are key challenges for all healthcare systems in EU countries. So in our recent publication, we show that the rising prices of cancer medicines have led to increased spending on cancer care, posing affordability challenges, even for affluent countries with publicly funded health systems. So the budget impact of new medicines is a significant factor affecting public coverage and reimbursement decision in most countries. So with higher drug prices and the increasing number of new medicines, it makes very difficult for some governments to provide fast access to oncology medicines. And in our analysis, we focus specifically on the reimbursement of cancer medicines for breast and lung cancer with a high clinical benefit. And we confirm that public coverage varies substantially across countries and specifically between Western Europe and Central Eastern countries. So just one key example, Germany reported that all indications were covered in 2023, followed by the Netherlands. But Latvia and Cyprus, for example, reported only a third of indication covered. And so we can see that the time from European-wide marketing authorization until national coverage range from around 100 days or less in Germany and Sweden to over 3 years in Cyprus and Latvia and also Lithuania. So it's both accessibility to reimbursed oncology medicines, but also time to coverage decisions that lead to disparities in cancer care across EU countries.
So Sebastian, from your previous experience engaging with regulators and payers in Eastern Europe, what structural barriers contribute to these access gaps?
Okay, so first of all, thank you very much for inviting me. I'm very pleased to join the discussion and answering the question. I have to say that in our sub-region Europe, we have a cluster which is called CEG, which is Central and Eastern Europe plus Greece, which is altogether 13 countries. And what's important to highlight, this is the countries with significantly lower GDP and limited spendings on healthcare. And I would like to express this, that our role is to ensure access to our medicine without limitations and in the shortest time possible. But speaking about the barriers, in order to understand this, we commissioned economist impact. And the one which I would like to highlight is a delay in the decision-making process.
Great. And then in your experience, how do budget constraints across government sectors, not just healthcare, affect availability and innovative treatments at a country level?
Of course, it depends on the country, but what we have observed that the oncology care and also healthcare is not everywhere a priority for the governments. Also, what is important to underline that the budget constraints significantly impact the quality of the cancer care. As I mentioned, we commissioned economist impact to investigate the barriers, especially for CEG, and there are many, like lower income countries faced with underdevelopment of healthcare workforce in oncology, or cancer care cost increases with disease stage. And there are competing priorities within the administration, causing limiting funding for oncology, missing knowledge, education, but also researchers. We always try to combine medical, payer, but also business interest when we discuss with the authorities, which is of course not easy. But our aim is to negotiate with the payer considering local affordability level through execution of innovative pricing. But one thing which I want to highlight is we don't want to compromise the value of our medicine we deliver to the market. As I mentioned, we have many challenges, but the one factor I would like to highlight is a delay in the decision-making process, which often comes from different priorities in terms of budget allocation.
Wow, interesting. And how do the main disparities in CE compare to Western Europe?
So here I want to maybe go beyond, disparities in access to oncology medicines, because in our work, we also present evidence on inequalities in cancer outcomes, which is very important for patients. So obviously, these inequalities are linked to inequalities in access to oncology care. But if you look at inequalities in cancer mortality by education level, we can see that the disparities are quite similar between Central Eastern European countries and Western European countries. They exist in all countries and they go in the same direction. This means that in both regions, we can see a socioeconomic gradient in cancer mortality. So mortality rates from cancer are consistently higher among people with lower level of education than those with higher level of education. But what we can see is that the social gradient, so the gap between low education and high education in cancer mortality rates, is much larger in Central Eastern European countries than in Western European countries. And this is true particularly among men. So again, some key numbers. We can see from IARC estimation that in Hungary and Poland, the mortality rates among low-educated men is double the mortality rates among high-educated men. But in Western countries, Western European countries, like in Belgium and Spain, the mortality rates among low-educated men is 50% higher than the mortality rates among high-educated men. So the disparities in cancer outcome by socioeconomic status exist everywhere in Europe, but it's deeper, larger in Central Eastern European countries. And maybe one last thing is that inequalities, socioeconomic inequalities in cancer outcomes, are explained by differences between social groups along the cancer spectrum. So from exposure to cancer risk factor, participation to screening programs, availability of health infrastructure, and access to oncology medicines.
So we hear about significant brain drain of healthcare professionals moving from CEE countries to Western Europe. How does this negatively impact cancer care?
So indeed, at the OECD, with our member states, we collect some comparable data on the migration of all physicians and nurses. And this data has been recently released in the 2024 edition of Health at a Glance Europe. So in this publication, we can see that in Italy, Ireland, United Kingdom, Germany, and Switzerland, among the EU foreign trained doctors, the main countries of origin are Romania, Bulgaria, and Poland. So these health workers leave the health system in a country for better job opportunity or better remuneration in other countries. And the mobility of health professionals can raise concern about brain drain or, care drain. But it can have serious negative impact on the quality, availability, and also equity of healthcare system. So this can be a big issue, for example, in countries that have joined the EU since 2004. So we can see, for example, in Romania, following its accession to the EU in 2007, that a large number of nurses trained in Romania have moved to work in other EU countries. But what we can see as well in recent years is that many countries from, Central and Eastern European parts have significantly increased the remuneration of the workforce over the past decade to narrow the pay gap between Western European countries, but also to reduce the financial incentive to move.
Sebastian, we often speak about a postcode lottery regarding access to treatment. Where you live impacts the access and even the quality of the care that you receive. And it often starts with participation in clinical trials. How do these disparities play out in countries? And do you see a gap between rural versus urban, richer versus poor regions?
I would say that people living in more developed countries or big centers are simply lucky. We see that the cancer care is concentrated to big centers or big cities, making unequal access for patients, and especially for those from small centers or other regions. To prevent this, additional investment in healthcare are required, but also some system changes. We should remember that cancer remains first or second leading cause of death. A healthy society will also lead to a stronger economy position in our countries. There is a nice report conducted by FPA, which is called Patient Weight Indicator Survey, which shows how much CEG countries are delaying in terms of access to oncology.
And do you see health literacy play a role whenever you're in deepening cancer care disparities? So patients currently have access to do more and more information, but is it being used near healthcare professionals as advocacy for better treatment?
So our reports, publications show clearly that disparities in health literacy is a key, to understand disparities in cancer care and cancer outcomes. low level of health literacy is more common among disadvantaged population, among low-income population, low education groups. And this explains why disadvantaged population are more likely to smoke, less likely to use screening program, and have less access to the healthcare system than their counterpart with higher level of income, higher level of education, for example. So at EU level, we show that around half of the population has inadequate or problematic level of health literacy. So this is a key issue, which explains inequalities, obviously. And so for people to lead healthy lives, they should have good level of health knowledge, of understanding of the healthcare system. So health literacy needs to be improved for all population groups and in particularly for disadvantaged population. And it also needs to be developed in collaboration with the target population. So I mean that governments, countries need to develop, for example, health education materials in partnership with the target population so that it's useful and understandable by the population, but also in collaboration with the healthcare professionals. So this will help to ensure that health literacy is increased, but both for an individual perspective, but also from the organizational perspective. So the role of health professional in developing this material is key indeed.
Yeah, education is so important for this. Yeah. Prevention and early detection are key components of oncology care overall. Have you seen any positive developments in CEE countries recently? And is there anyone doing it especially well?
So yes, indeed, we can see some positive development and good policy example in all reports that we produced. We did this exercise in 2023, and we have the new profile with update on all policy for 2025. So I would say that one key country example for me in this region is Slovenia for both primary prevention and secondary prevention, early detection. So on primary prevention, Slovenia is implementing some of the strongest nutrition policies to address overweight and obesity, which is an important cancer risk factor, as you know.
Yep.
So it includes, for example, engagement with the food industry on food reformulation, taxation, regulation of marketing of unhealthy food to young people, labeling of food products, or regulation of availability of unhealthy food. But it also includes, an important role of primary health care for counseling. So it's really a comprehensive package of prevention policies that is implemented in Slovenia, and this is key strategy to address risk factor for cancer. And a second example that I will say for early detection is that Slovenia is among the few EU countries to have above 50% participation rates on all 3 cancer screening programs, so breast, cervical, and colorectal cancer screening programs. So the country has implemented population-based screening programs for these 3 cancer sites. So this is very good, but it's also combined with several other important policies, such as peer-to-peer helpers to inform people about screening, early detection, public awareness campaigns, reminders sent by primary care provider, mobile breast cancer units, but also fast-track pathway for cancer diagnosis. So again, the combination of all these policies is a good sign and a positive development, for having early diagnosis of cancer, which will improve the chance of survival. And this is not done by all countries, obviously.
And what role have you seen regulators and local policymakers playing in ensuring affordability and faster innovative therapies? And what can pharma companies do more or better to support their work when it comes to regulatory readiness and even pricing and access?
I think that on the beginning, we need 2 things, decision makers awareness and cooperation. This is critical to engage all stakeholders and make collective decision in terms of cancer care improvement. This is what we have observed in many countries, including Poland. I think that the role of pharma is big, but not the only one. Pharma companies could be a driver of this kind of initiatives, having access to data and studies. Thus, it's important to be one and together with healthcare community.
Caroline, what are some of the encouraging signs of progress in cancer care equity?
It's a difficult question because so far we have not seen a reduction of inequalities in cancer care and outcome within countries. So, for example, by socioeconomic status. But what is positive is that more and more countries are developing initiatives to reach the most vulnerable population. So, for example, to increase awareness of cancer, its related symptoms, the benefit of screening. There is also positive development to adapt healthcare services and to establish delivery models that reach vulnerable population in the local community. So key examples that I have in mind is, for example, Estonia. Estonia has developed 3 mobile mammogram buses. So it has a key role in bringing cancer screening to people in the community where people live and work. So really mobile cancer screening programs are in development in many countries, including in Estonia. Again, Slovenia. Slovenia makes invitation to screening or online education guides, video messages, and other information available in various languages. And this is very important to reach people with a different cultural background. And the last example that I want to give is Hungary, which provide citizens with the option to self-test at home for example, for colorectal cancer screening. Mm-hmm. There are also screening buses that are organized to specific location where invitation and test kits are provided to communities. So again, it's very important to reach the people that are far from the healthcare system.
That's great. Final question for you both you and Caroline. Looking ahead, if you had to name one key priority to improve cancer care in CEE countries, what would that be? You want to start with you, Sebastian, and then?
Yes. So, of course, social discussion and like a debate, consensus regarding improving of cancer care is required, but of course it will take time. So let's start from, for instance, quick adoption of the latest EU initiatives, which is joint clinical assessment. The GCA could be a game changer for countries in CEG. Mm-hmm. We can get access with high quality clinical assessment. It means faster access, more precise decision-making process, still having local financial economic assessment and then local negotiation. Of course, it will not replace the national processes. Small countries with limited HTA capacities can now rely on the EU standards. In short, GCA could give us a quality and speed, two things which we have been chasing for years.
Great. And Caroline, any thoughts from you?
I do have several key priorities in mind, but I will maybe focus on 2 key priorities. So the first one is to invest in prevention to address cancer risk factors and reduce inequalities between population groups, but also between countries. So we really need to remind policymakers, business, and civil society that investing in healthy lifestyles and environment not only saves money for the healthcare system, but it boosts as well the economy, keeping workers productive. And the second one is that to improve cancer performance and address inequalities in cancer care, countries need to monitor and benchmark performance. So data is the key foundation for designing cancer control and care policies that are truly effective, efficient, and equitable for all citizens. So countries need to strengthen current information system, for example, to monitor simple things, but available resources like the number of oncologists. It's not done regularly by all countries today. Access to cancer drugs, waiting time for cancer care, but more importantly, to collect patient-reported indicator survey. This is very limited in EU countries, so we need to invest in collecting PRAMS and PROMS indicator. So we have launched at the OECD the patient-reported indicator survey, the PARIS survey, And this fills the important gap that we can see today. And so I invite all of you to consult the OECD website to have more information on the new Paris survey.
I want to thank you both for these great insights and for sharing your valuable experience. Despite existing challenges, we could see there's a positive trend to bridge the gap between Western and Eastern Europe, and with some CEE countries doing great work that can inspire more developed economies. So thank you both for being on. Thank you to our listeners for listening. Be sure to follow us on your favorite podcast platform, and we will talk to you all next month at our next podcast. Thank you so much.
Thank you.
Thank you very much.
Be sure to follow us and subscribe to our podcast on Amazon, Spotify, Apple, or iHeart. You can also subscribe to the video version of the podcast on YouTube. Thanks so much.